Welcome to this short lecture on liver function tests, or LFTs. Now this particular lecture will cover 7 tests. So we'll go through 7 tests, what they are, when they can possibly be out of range, and some more specific examples of times of abnormalities. Okay, so let's start with this image here. So obviously today we're going to be talking about the liver. And so what you can see here is we've got a liver, we've got the hepatobiliary tract in green, and we've got the blood vessels in red. Now the reason I've done that is because these function tests, which I'll draw up in a second, will be color-coded to these structures. So the liver itself I put black, okay, and the tests that are specific to liver injury I will put in a black color. Whereas in green, which is the hepatobiliary tract, which is the excretion portion of the liver, is in green, so I'll write the test in green. And then finally the blood, which is a combination of the portal vein and the hepatic artery. Remember, 2/3 of the blood to the liver is portal vein and 1/3 is hepatic. So if it is more of a blood specific dysfunction, I'm going to put that in red. So let's go and fill the 7 tests. The first one is bilirubin. Okay, so we've got that in red. Now, just bear in mind, today is going to be a very shortened, truncated lecture, so it's not going to be very exhaustive. I'm just trying to put it all together very briefly so you can just see how the tests are, how they're arranged, what they are, when they are potentially out of range, and some examples. So it's not going to be hugely exhaustive, so if you need more details you might have to explore other resources. So the bilirubin is going to be more specific to the blood. Okay, we have albumin, we've got PT, which is prothrombin, and we've got AST and ALT, and then in green we've got ALP and GGT. I'll go through what these acronyms mean in a second. So what we can see so far, we've got 1 red, so that's going to be more specific to potentially the blood. We've got 1, 2, 3, 4 specific to the liver, so this is going to be hepatocellular specific. And then 2 green, which is more to hepatobiliary, so this is more to the biliary duct system. So that's the excretion side of things. Now with bilirubin, we'll start with bilirubin. So bilirubin essentially is the breakdown product of HB, which is hemoglobin. So the breakdown product of hemoglobin is essentially going to be what bilirubin is, and it's going to be, so we've done this in a separate lecture, so I encourage you to go and have a look at that. That will be in jaundice. So hemoglobin is broken down, it's recycled in different manners, so the iron's taken someplace, protein's taken in a different place, and hemoglobin has to go to the liver to make it water soluble. Okay? Now, therefore the liver will conjugate it, liver conjugates, okay, and liver excretes. Okay, so let's put an important point here, because in a way, even though I've got it in red, if you want to be technical, it can actually be 3 colours. So it can be all 3. It can be, I'll put Billy, Ru, and then Bin in green. So technically bilirubin, the level of bilirubin, can, if it's going to be high, you need to explore things that can dictate whether there is an obstruction, so a problem with the ductal system, a problem in the blood, so too much hemolysis, too much breakdown, too much red blood cell destruction, or a problem with the liver. And so these are the 3. So in the blood side of things, there's probably excessive bilirubin when there's excessive red blood cell destruction. Okay? So the first test, bilirubin, this is a blood test from a breakdown of hemoglobin. And so if this bilirubin, or the total bilirubin, goes up, it could be a cause from in the blood, which is red blood cell destruction. Or it could be from a liver cause, okay, which is hepatic injury, hepatocellular injury. An example of that would be cirrhosis, okay. And then finally, the other cause of some bilirubin issues would be an obstruction in the ductal system, so a biliary tract obstruction. So basically what you'll have to look here is, if you took blood levels, you would have to figure out, well, if the total bilirubin is high, whether it is from before the liver cause, that's a pre-hepatic cause, and so that's excessive amount of bilirubin going to the liver, and it's kind of overwhelming the liver's ability to be able to conjugate it. Okay, and so once you look at the total bilirubin levels, okay, so if the total bilirubin is up, okay, and it's overwhelming the ability to conjugate it, so it will be proportionally higher amounts of unconjugated to total amount, and that would tell you it is a pre-hepatic cause. So examples would be pre-hepatic, could be due to bleeds, Gilbert's syndrome, or just excessive hemolysis. Okay, now if the level is high, bilirubin level is high, so the total amount is high, but there's a combination of it maybe being conjugated or unconjugated, and you're not really sure, so it's kind of swinging between. It could be a hepatic cause, which, for example, could be cirrhosis. Now, the last one would be a post-hepatic cause. Okay, and what would happen there is the total could be slightly high, but the proportion would be mostly conjugated, because the liver is conjugating and it's excreting, but you've got a blockage. Okay, so the excretion can't get past there, and so it comes back, and then it will enter the bloodstream, and so the conjugated levels is high. So if you have bilirubin raised, but the high proportion of it, the majority of it is conjugated, you can guess that it's post-hepatic caused. Okay, and examples would be an obstruction in the biliary tract. Okay, so that's bilirubin done. Now moving to albumin. Now albumin is purely done by the liver, so it is made. So it's the most abundant plasma protein in your plasma in your blood. It's made by the liver. Okay, it helps. Its function is to help transportation. So it functions to help transfer things like hormones, bilirubin, fats, drugs. It also is very important for the oncotic pressure in your blood. So the oncotic pressure. So that's the suck-in pressure. So that will pull fluid back into your blood vessels. So if you have a low albumin, plasma can't get back in, so you can get certain edema states. And so this is what albumin is. It's very important to know that it's made by the liver. Okay. Now, when is it likely to be out of whack? Well, an easy way to remember this is in states of osis. So you could have cirrhosis, okay, or you could have nephrosis, or you could have gastrosis. And what that means is, this is like a condition. Cirrhosis is a problem with the liver, and so in this case, it's just not making albumin. So albumin levels is low. You can't have high albumin levels. You can either have normal or low amounts. So with the cirrhotic causes, cirrhosis causes, your liver's just not making it, so it's going to be low. In the nephrosis causes, this is where your liver, the glomerulus is leaking, and so you're losing albumin through the urine, and so the levels will drop. or the gastrosis causes is where you've got a problem with either absorbing the proteins across your intestines, so you become malnourished and you get the low albumin, or you get a leaky kind of intestines and you lose it that way. Okay. Now with albumin, it is most sensitive with chronic liver. So when we're specific to, say, cirrhosis, liver conditions affecting the albumin levels, it's most specific to chronic liver injuries, not so much acute onsets. And that's because it takes about 20 days half-life to get rid of albumin out of the blood. So it's really the more long-standing liver diseases where this albumin test is going to be more sensitive. Okay. Now we move to prothrombin. Prothrombin is essentially the coagulability in the blood. So the coagulability of blood. And so essentially this is the way that the blood clots. Okay, so this is with thrombin and prothrombin and all that stuff. And so this is just the speed on how quick the blood can actually clot. And so the majority of the enzymes that do this is made by the liver. Okay, enzymes are made in the liver. So there's many vitamin K dependent enzymes that the liver makes, which is highly dependent on the speed of clotting. So therefore, out of all the actual tests, prothrombin is actually the most sensitive. And the reason why that is it will work in both an acute and a chronic state, and it will kind of dictate the severity and how things are progressing, because all these enzymes are within the liver, okay, and if they're out of balance, not being made, therefore this whole thing breaks down, and it will give you an indication of how damaged or how problematic the liver is. So that's a very sensitive test. However, it's important to note that some things, like vitamin K deficiency, certain anticoagulants, and haemophilia will change this around. So these conditions will have an impact on prothrombin time, and so you need to take that into consideration if your patients may have these, because that will affect the sensitivity of this test. Okay. Now, really, it's important to note that these three tests that we've just done is all about the liver synthesizing things. So these are specific to liver making or liver creating or liver modifying things. So that will give you a good indication of the functionality of the liver. Now, these last four, okay, are specific to separation of hepatocellular injury, so liver injury specifically, or liver injury as a result of obstruction or the hepatobiliary tract occlusion. So these are important to these four tests. These will separate those two conditions, whether it's a hepatocellular origin or whether it is from a biliary obstruction origin. So going now on to these two enzymes within the liver, the ALT and the AST. ALT is alanine transferase, so it's an enzyme within the liver, and it helps to add the amino group to amino acids in the Krebs cycle, and it is specific to the liver, so it only happens in the liver only. Now compare that to AST, which is aspartate transferase, so they're both transferase enzymes. So this is an enzyme also in the liver, and it helps to add the nitrogen end to the amino acids in the Krebs cycle. Okay, amino acid in Krebs. But it's also found in other muscles. So it's found in skeletal muscle, cardiac, and kidney. Now, when would these guys specific to the liver be up? Well, it's usually with acute inflammation. So, inflammation, so inflammatory states, and it's usually more acute. But it's important to note that this will be specific to the liver. So when that's up, it's only really the liver problem, whereas this one, you could have false positives in muscle trauma, heart issues, heart failure, or kidney problems. So it's important to note that you might see this one here, the AST, raised in other external issues. So that's noteworthy. I'm not going to go across into the examples as yet. I'm going to go through these two before we continue. Now, the ALP is alkaline phosphatase, and this is, it can be found in hepatocytes, but it's more in the canalculite. So it's more in the cells as we go into the ductal system. So, liver, but more in the biliary system or cells. Okay. However, it's also found within placenta and in bone. So it's also in bone and placenta cells. Okay. And then finally we've got GGT, which is gamma glutamyl transferase. Okay. It's important for transporting amino acids across cell membranes. This is not specific to the liver. It can be also found in other places, also in kidney and pancreas, as well as in the liver and in the hepatobiliary tree. Okay, so it's also noteworthy to be found in alcohol or alcoholic liver conditions. That's important, but it's very sensitive but non-specific. And this one is very sensitive for biliary obstruction, but non-specific again. So, before we go into these examples of when they occur, just a quick run through, at least with these guys. So we've got the ALT and AST, which is specific to liver dysfunction, liver injury, more around the inflammatory states. So what I mean, if you've got a chronic liver issue and it's not reoccurring, these aren't necessarily going to be raised. But when you have an active process occurring, these are much more sensitive. Now, when it comes to ALP and GGT, these are going to be much more specific to the hepatobiliary system. So if you have an obstruction, you're more likely to see these increased. So let's go and have a look at when you are assessing. So one of the first screens that you could look at is looking at ALT and ALP levels. Now, if you were to see a higher amount of ALT to ALP, that would be indicative of liver-specific injury. So with a liver-specific, even though we've got ALP in green and we're talking about hepatobiliary tract, it can still go up with liver injury. But if the amount is much higher in the ALT range versus a more modest increase with the ALP, it will suggest liver injury or hepatocellular injury. So bigger, I'll put 2 arrows up, is hepatocellular versus only a modest increase. 1 arrow would be less likely. But if you were to get the other way around, so a much bigger increase proportional to what it should be normally. So let's say you have 2 arrows here and only a 1 arrow here, it's more likely to be an obstructive case. So there's usually a blockage and it's coming down and it can't get past, so it's releasing the enzymes, it's releasing the alkaline phosphatase, which is becoming injurious, and that's causing it to be high. but it's causing a higher amount relative to its normal levels compared to the ALT levels. However, because it's non-specific, it's also found in bone and placenta, you want to run a GGT in response to it. So if the GGT is high with it, it's likely to be an obstruction, okay, a hepatobiliary obstruction. But if the GGT levels are normal, it could be indicative of a bone issue. So it could be a problem with something like an active bone condition like Paget's disease, or a tumour within an active tumour growth, possibly a recent fracture, something like that. So this is how these guys fit in. Now, when you compare these two, so these are specific to hepatocellular. Now, both of them will be hugely high in very active cases like active hepatitis, viral hepatitis like A's and B's, hepatitis A and hepatitis B. Also, it's going to be high in ischemic, liver ischemic injury, very high levels. Now, where they could be distinguished, okay, relative to each other, if you have a higher ratio of ALT to AST, it's more likely to be chronic liver injury. And then if you have, let's say, higher AST to high, modest ALT, it's likely to be maybe cirrhotic, cirrhosis, and an alcohol base. So that's really the 7 tests. What we can see as a summary, we've seen there's 3 tests that are specific to being synthesized in the liver, and then you've got these 4 here, which are enzymes associated with either the liver or the hepatobiliary duct. And so when there is injury, just like you get with a heart attack, you start to get enzymes released. Now, firstly, with these guys, these are specific to kind of liver and the synthesis of the liver, or the way that the liver processes. So bilirubin, if bilirubin levels are high, it could indicate that it could be a prehepatic cause, so there's too much red blood cell breakdown, such as Gilbert syndrome, bleeds, or hemolysis, and that's causing too much going to it. But you want to check if there is a high proportion of unconjugated, okay, to conjugated, which would suggest a prehepatic cause. If it is a posthepatic bilirubin, so you're going to have much more conjugated relative to the total amount. And then in the hepatic or the cirrhotic cause, so it's actually a problem with the liver, it's going to be a higher bilirubin, but it could be a combination of unconjugated and conjugated. It's very hard to distinguish in that point. Albumin, because it's specific to being produced in the liver, okay, so it's indicating that, and it's much better with chronic liver injury because the half-life of albumin is over 20 days, okay, and so if the liver has been dysfunctional for a long period of time, the albumin level will drop. Prothrombin is all about coagulability, so this is the most sensitive test, and it can be indicative of how things are progressing or how acute it is. Okay, but you've got to note that if the patient's got any of these things like coagulants, they're taking coagulants, haemophilia or vitamin K deficiency, this is going to be less sensitive. And then finally we go down to the 4 tests. You've got 2 enzymes specific in the liver and 2 enzymes more to do with the hepatobiliary tract. So if these guys are increased, the ALT and the AST, this is specific to hepatocellular injury, and you want to discern how the ratio is different to decide whether it's a chronic kind of issue or maybe alcohol-driven issue. But you also want to see these ones here to see whether it's an obstruction, so it's a biliary tract obstruction. But do bear in mind that if it is a very acute obstruction versus a chronic obstruction like cancer or stenosis, if it's an acute obstruction, because it will be shocking the liver very acutely, you might get a fairly increased raised amount of AST and ALT, so that might be a difficult one to be able to see. But you would then check with the GGT to confirm that it is biliary, and then you'd have to probably do an ultrasound or something to find that obstruction. So hopefully this has somewhat helped you to understand the liver function tests, what the 7 are, and when they're likely to be raised and out of whack, and then in the examples of when they're likely to be.